Hi everyone, and thanks for joining in on our NC UK Summit today. My name's Irene Wotherspoon and I'm an advanced clinical nurse specialist in neuroendocrine and thyroid cancer, and I'm based at the West of Scotland Cancer Centre in Glasgow, where we care for half the population of Scotland. Today I'm going to be talking to you about decision making in your care and how we can make it work for you or work better for you. So the aims of this session today are to discuss the frameworks which underpin us as healthcare professionals in our decision-making practice, to empower you to be part of that decision-making process in your care, and to explore the current government guidelines concerned with shared decision-making. So what is shared decision-making? Shared decision-making is a process whereby clinicians work collaboratively with patients to reach evidence-informed and value-congruent medical decisions. Now, I should say that I'm probably going to interchange people and patients and families and carers. Sometimes we need to do that because each person's perspective on whether they see themselves as a person with an illness or they actually see themselves as a patient, which some people do. So I'll use that term interchangeably and hopefully you won't be offended. So starting off with Scotland, there's been a recent Scottish Government document which has been published by the Deputy Medical Officer, and it's titled Realistic Medicine. The key parts of realistic medicine are listening to understand patients' problems and preferences, sharing decision-making between healthcare professionals and their patients, ensuring that patients have all the understandable information that they need to make an informed choice. Now you'll see as we go through these and then we go on to some of the other documents that some of the statements are very similar. One of the things that I want to point out is this notion of understandable information, because it talks about written information and informed consent and that we must listen. But as healthcare professionals, we've got to make sure that you understand what it is we are giving you information about and what that actually means to you. So it's actually important, but sometimes a bit strange when a healthcare professional might say to you, can you tell me what you understand about what I've just told you? Because we don't know what you've understood unless we check with you. So that's something which is actually very important. We need to move away from the doctor knows best culture to ensure a more equal partnership with people. And that it was very much of the day gone by, and probably your parents and their parents who would say the doctor knows best and you don't challenge the doctor and you just do whatever the doctor says. And going back then, doctors were very paternalistic because what they learned was to be paternalistic about doing the best for their patients and that they did know best. But we have to take into account people's circumstances, people's preferences, people's lifestyles to actually, so we don't know best, you know best. So going on, supporting healthcare professionals to be innovative, to pursue continuous quality improvement and manage risk better. So what this means is about supporting us to actually have greater flexibility, to have different ideas about how we deliver healthcare. And I think that's something we've had to learn to do very quickly this year because of COVID. So it's something, great skills that we've learned that we can take forward. But also we need to be measuring what we're doing to make sure that the quality is of a satisfactory level and of a high level to the people who are receiving the healthcare. We must reduce harm and waste caused by both over-provision and under-provision of healthcare. Because we have so many resources available now compared to what we had 10, 20 years ago, we can't adapt the approach of just because we can, we should, because sometimes we shouldn't. Because as much as we have access to different scanners, more superior scanners, for example, different drugs, more expensive drugs, it doesn't mean that that's always what we should do. So we have to think carefully about what is the best way forward. And we should identify and reduce unwarranted differences in practice. And this is very important so that we are providing continuity of care so that everybody is getting the same standard. So people might not be getting the same treatment, but they should be getting the same standard of care. NHS England produced a document recently as well, and the web address is there on the page if you want to read the full document, and it is quite interesting, called Universal Personalised Care. So again, it strives to reach shared decision making, personalised care and support planning, enabling choice, including legal rights to choice, and we'll talk a bit more about that later. Social prescribing and community-based support. And this is very important. I work in an acute hospital, and for those of you who I see, and those of you who will be in a similar position to the people I see, going to the hospital for your treatment or a consultation is a fraction of your lives, a tiny, tiny fraction. The majority of the time you're at home, you're in your community. So therefore, what is being addressed and acknowledged even more so than it already has done is that people do live in social communities. That's where they are and where they need community-based support. That's particularly for people who are living with long-term conditions, which many of you are, people with mental health conditions, people with learning disabilities, so people that need ongoing support in their lives. Supported self-management, so therefore empowering people to be able to manage themselves and their own health and social situations. And personal health budgets and integrated personal budgets, again, are for people who have long-term conditions or who are needing ongoing health and social care support. So that was the key aspect of that. The Department of Health from Northern Ireland have a document, Transforming Your Care, and similarly they are placing the individual at the centre of the model by promoting a better outcome for the service user, the carer and the family. And how they're doing that is by using outcomes and quality evidence to shape their services. So what have we learned before and what can we use that for in the future, which is positive. Providing the right care in the right place at the right time. So yeah, providing the right care, trying to keep people at home and in their own environments, their own communities with their family, and actually doing that when they need it, and avoiding crisis management. Population-based planning of services, and that's particularly relevant for rural communities that we have around the country. And a focus on prevention, so health promotion, prevention and tackling inequalities again, so that people can access the same care regardless of where they live, regardless of their gender, of their ethnicity, etc. They go on to talk about integrated care and working together. So that's the patient, the service user, whatever term you want to use, and the healthcare professionals that are there, and the social care professionals, because again, that is something which is very important. And certainly recently in Scotland, health and social care have become increasingly integrated. Promoting independence and personalisation of care, so again, empowering people, safeguarding vulnerable people so that things are prevented rather than having to be dealt with in a reactive fashion. Realising value for money, so again, considering over-provision and under-provision and trying to get it right. Maximising the use of technology, which is an example of what we're doing now, because normally I would be standing in front of you in person delivering this and allowing you to give me questions and challenge what I'm saying. Incentivising innovation at a local level. So we can see that throughout the country this is being addressed by these government guidelines and documents to then be put into place. So when I was asked to do this, I thought, patient involvement and decision making, why are we talking about that? Is that not something that we do and that we already do really well? And I kind of thought we do. So, my question is patient involvement a new concept? It shouldn't be, but quite clearly, given I've been asked to talk about this subject, it must still be an issue. And of course, it's easy for me to say as a healthcare professional that I give everybody information. I always check they understand the information and we know we couldn't do it better. But there's something telling me that quite evidently we can. So what underpins what we do? So from a nursing point of view, I have to abide by nursing and midwifery. It's called the Code, and it's professional standards for practice and behaviour for nurses, midwives and nursing assistants. The GMC have a document which is just about to be an updated version come out next month. Good medical practice, and it's got increasingly greater pointers for decision making and consent. And I always like to refer to Beauchamp and Childress, they're American ethicists who produced ethics of biomedical science, which is something that I studied when I did my master's degree a number of years ago, and I find it just fascinating, and I think it's something that all healthcare professionals should be aware of. So from a nursing point of view, what does the code say? So it says a lot, but what's particularly pertinent to decision making is that we should be encouraging and empowering people to share in decisions about their treatment and care. So what's going to work for you? These are the treatments we have an option. These are the side effects you might get. This is the burdens of taking this treatment. This is the benefits. And then getting people to empowering them with that information and getting them to make their own decision. We should be respecting the level to which people receiving care want to be involved in decisions about their own health, well-being and care. And this is an interesting one because it kind of flips the first statement on its head. Because there are some people who don't want to be involved in decision making about what treatment they get, about which hospital they're in, about whether they go to a hospice at this point in time, about whether they go home, about whether they have their injections in home care or whether they come into the hospital. But that is a decision in itself. If somebody decides that they don't want to make these individual decisions, they want the doctor to do it, the healthcare professional, you know, their daughter, their son, their husband, then that's fine. We have to respect that decision. We must respect, support and document a person's right to accept or refuse care and treatment. And that is, again, something which can be tricky for us as healthcare professionals, because not always do people want to accept our advice or guidance, our education, our counselling. They sometimes don't want our drugs, they don't want our investigations. And that's okay, as long as we check out that they fully understand, again, as much as possible, what the implications are. Then if people don't want to engage in certain things, then that's okay. But we must, as I say, discuss that using very good communication skills to be clear we understand each other. We must make sure that we get properly informed consent and document it before carrying out any action. Again, as I've said, and probably labouring the point, we don't know what people know and understand until we put it back to them to explain to us. We should share with people, their families, their carers, as far as the law allows, the information they want to know about their health care and ongoing treatment, and sensitively and in a way that they can understand. And this is something that can pose issues sometimes because often family and close friends will feel that they should know everything, that they should be privy to all the information, the same as their relative is, particularly if they're next of kin. But I'm afraid that that's not the case. The information belongs to the patient, the person with the illness, and it's absolutely their decision about what they want shared with their family and their friends. There isn't any legal right to have access to information, certainly not in Scotland, there's not. So that's something which can be very difficult. It can also be tricky for all of us when a patient perhaps is very unwell and doesn't want to know their prognosis or what's going to happen next, but their family does. And the patient doesn't mind if their family wants to know, because we then have a patient and we have family on two different levels, and that can be very difficult. But that is down to the patient's decision, which we must respect, and we must manage that. So in medicine, our doctor colleagues are advised to listen and take account of views and respond honestly, give information they want or need in a way that they can understand. So that's stressing that point again. Treat patients fairly and respect whatever their life choices and beliefs. And that can be difficult if people have negative health views and negative habits. But it's our position to provide health promotion, but we have to respect people. We must again share information to allow them to make decisions, listen to and respond to their concerns and preferences, respect patients' right to reach decisions with you about their treatment and care. So it's not just all about what we should do medically to manage something. We've got to, as a team, as your healthcare team, we have to know and understand what's important to you, what your family circumstances, social, financial, how your psychological and mental health is, what support networks you have, because all of these have an impact on how you cope with your treatment and how you cope with your illness, and therefore what is going to work best for you. So we must be honest and trustworthy in all our communication So we have to make clear the limits of our knowledge and make reasonable checks to make sure any information we give is accurate. None of us is the font of all knowledge, and we've often got to refer to other people, to colleagues, to say, well, have you had an experience with this? Particularly in the world of neuroendocrine neoplasms, where they are much less common than other cancers, so they're less well known, less well understood. So we often have to share our experiences with colleagues and learn from anecdotal evidence sometimes. So this goes on to say all patients have the right to be involved in decisions about treatment and care, and supported to make decisions. Decision making is an ongoing process, so it's not a situation that it's at the first consultation and that's it done. It needs to be an ongoing process. How are you getting on with this treatment? Do you want to engage in these investigations? We want to do a CT scan next month. Do you want to have a CT scan next month? Does that suit you? No, I'm going on holiday, I'm doing whatever, I've got a meeting, I'm going away, so I'm on business. So sometimes, we have to say, well, we'll work this round too. So you all have the right to be listened to and given the information you need. We must find out what matters to you so we can share the relevant information about benefits and harms of proposed options. So for somebody who lives alone, it would be much more risky to give a highly toxic chemotherapy regime than it would to somebody who lives with somebody else who can be there to monitor them. So that's an example of how we have to think about circumstances. Doctors must start from the presumption that all adults have got the capacity to make decisions. A patient can only be judged to lack capacity after specific assessments. So there's a formal assessment we have to engage in to do that. But still, somebody who lacks capacity can still be involved in their treatment decisions. That doesn't mean to say that their thoughts and views and circumstances are ignored. And patients whose right to consent is affected by law should be supported and still, as I say, involved in choice. So moving on to the final framework, which is that of ethics of Beauchamp and Childress. And the principles of biomedical ethics are autonomy, maleficence, non-beneficence, and justice. Autonomy is respect for individuals to make their own decisions based on, as I've said, that thorough information. But it's also respecting people who do not want to make the decision, who will leave that to their doctor or their nurse or to a family member. And we mustn't be paternal. We don't know what's best for the person we've got in front of us. They know what's best. Non-maleficence is that we should do no harm. And if we're using a drug or a treatment, radiotherapy, which has got toxic side effects, we must minimise the harm. We must also consider burdens and benefits, what the side effects are, what the symptoms of the treatment may be, what the prognosis is, because giving a highly toxic regime to somebody with a very short prognosis is not necessarily the right thing to do. And we have to know, again, remind ourselves what is important to the patient. Beneficence, all treatment must have a net benefit without a doubt. We can't give a treatment if it's going to have more of a negative impact than a positive impact, even if somebody demands to have that treatment. And unfortunately, there are treatments which will be futile. And if things are considered medically futile, i.e. they are not going to work, they will not be offered. So where somebody requires treatment, they will be given options of what would work. They'll not be given options of what wouldn't work. So things that are not available. And the way it is, treatments can't be demanded upon because if they're considered. So again, giving chemotherapy to somebody who has very poor liver function, we wouldn't be able to do chemotherapy in that situation because the treatment would be futile and it would make the person more unwell than they were to start off with. Cardiopulmonary resuscitation is a massive can of worms, but is one of the treatments that is medically futile in the majority of us. The majority of people who are well. For anybody who, for whatever reason, stopped breathing or their heart stopped working when they were outside of a hospital, their chance of full recovery is much less than 5%, and that's for everybody, including young, fit people. So it's a medically futile treatment for the majority of people. And justice is that patients in similar positions get treated in a similar manner. So essentially, all of you who are watching this should be treated in a similar manner regardless of what part of the country you're in, regardless of your colour, of your religion. Everybody should be treated in a similar way. But also as healthcare professionals, we've got to consider costs, we've got to consider risks, because where a treatment is going to cost a massive amount of money with very little benefit or very little chance of being effective, we have to consider that and it's a very difficult thing to do, as you can imagine, for healthcare professionals who want to make people better to have to consider cost, but it is something we have to do so that somebody else who would benefit more from that treatment can access that treatment, because the purse, unfortunately, doesn't have it's not a bottomless pit. So just a couple of, I've got a case study, and this is quite brief, but it was a case 2015, ironically in NHS Lanarkshire, which is the area in which I live actually, but this has changed a lot of things in the approach to medical negligence with regard to information giving. So it was a lady who was pregnant, she was diabetic, and she was of short stature. And because she was diabetic and of short stature and tending to have a bigger baby, there was a 9 to 10% chance, which is quite high, of the baby getting stuck in the pelvis as she was delivering the baby. She wasn't told about that, and if she was told about that, she would have been given the option of a caesarean or to try a vaginal delivery. But she wasn't given the option, and the baby did get stuck at its shoulders, because the baby's shoulders were wide going through the pelvis. And because of that, the baby suffered a lack of oxygen to the brain, or hypoxia, and the baby was born with cerebral palsy. So this case was taken to court, and the lady won the case, but it's changed, as I say, the approach to medical negligence, that now what's got to happen is that patients have got to be told about the side effects of drugs, the side effects of procedures, even if that's small. They have to be informed of them so that they can make a decision. It's not up to the medical professional or the nurse or whoever to say, well, the chance is so low, it's only going to worry them. I'm not going to burden them with that. It's not for the doctor or the healthcare professional to decide. It's the patient is given the opportunity to know what the side effects and what the risks are. If they choose not to, okay, but again, that needs to be dealt with delicate communication skills. However, the patient can choose not to be told the risks, but we must go in favour of giving the patient or the person all of the information for them to make a decision. So that, as I say, it's changed things quite considerably across the country and across the world. And just a quick case study just to explain some of the things I get involved in as a nurse specialist, which I'm sure lots of my other colleagues do. It's a case very recently, actually, just a couple of weeks ago, of an 82-year-old man with a grade 1 neuroendocrine tumour of bowel, under control, stable disease, but he got admitted to hospital with constipation, and when he got there, they discovered that his kidneys weren't working very well. So they did a CT scan, and that unfortunately revealed a large tumour in his bladder, which was blocking the tube that comes from the kidney to the bladder, and it also was invading into his prostate gland, and there was lots of cancer, unfortunately, in his liver. So he got discussed at the local multidisciplinary team. He had a previous history of bladder cancer, and they felt they wanted to do a liver biopsy to find out what this was. Then unfortunately, the radiologist said, well, I'm not going to do the liver biopsy. It seems quite obvious to me that this is an occurrence of the bladder cancer. So that kind of got left at that, and he kind of fell between stools. So his wife phoned me to say, look, he's been in hospital, he's really not well, he's got this tumour, we don't know what's going on, we don't know whether it's the net. And she was very worried because he was weak, poor appetite, poor concentration. So as you would imagine, we most thought it was most likely the recurrence of the bladder cancer, because the grade 1 neuroendocrine tumour, as you know, are very slow growing things. But when I was discussing it with his wife, I'd explained to her that a liver biopsy is quite invasive. It involves a jaggy needle. There's a risk of bleeding, there's a risk of pain, there's a risk of biopsy failure if the needle doesn't hit a bit of tumour. So it's quite invasive, quite a lot of risks attached to it. And they weren't sure that they really wanted to do that. And they said, well, actually, we don't. The consultant said to me, not my consultant, but said, well, it's not invasive. But I suppose what are you measuring it against? Are you measuring it against major abdominal surgery? But still, it's quite invasive having a needle entering the liver, which is an organ with a massive blood supply. So nothing really happened. I contacted the team associated with this. The patient got admitted again with more constipation due to pressure on the intestine. So they decided at that point, well, actually what we'll do is we'll put a scope into the bladder and get a biopsy that way, which seemed a much more acceptable approach to everybody because it's much less invasive. The risks are much less because you're not hopefully penetrating anything and not going into any tissue other than the tumour tissue. So the things that I had to consider there was it was unlikely to be due to neuroendocrine neoplasm, but what if? And it was felt very much from the oncologists it was important to get tissue because the chemotherapy treatments are vastly different. But really we should be thinking about a least invasive way to get a biopsy. But what if the patient, say you get the biopsy back, it says it's very aggressive bladder cancer, and the treatment is very aggressive chemotherapy. If you've got somebody who's lost weight, who's not fit, who's sleeping, are they going to be fit for treatment? So is it the right thing to do a biopsy in the first place? So very much you have to consider with any of these type of decisions about the ethical principles, the burdens and benefits, the decision making, the patient being involved, the family being involved, the multidisciplinary team. And what is really important is having excellent communication skills to be able to deal with these situations. So I hope you've enjoyed it. Thank you very much for paying attention, which I assume you've all been doing. And I hope you enjoy the rest of your day. Thank you.